So, presenting a case of 24-year-old female A, housewife by occupation, wife of B, living in Vadodara, has an income of rupees 3,000 per month, is Hindu by religion of the upper lower socioeconomic class by modified Kupaswamy scale. She presents to the OPD of OBGYN for routine antenatal checkup. She is a case of 37 weeks, 0 days pregnancy, second gravida with previous cesarean section. She does not have any history of pain in abdomen or back, leaking per vaginum or bleeding per vaginum, or any history of decreased fecal movements. She has had her menarche at 13 years of age. Her past cycles have been regular, 30-day cycles with flow lasting for 5 days, normal in quantity, no pain or passage of clots. There is no history of dysmenorrhea or heavy menstrual bleeding in the prior menstrual cycles. She has had an active married life of 5 years. Non-consanguineous. Obstetric history is G2P1A0L1. Spontaneous second. Her LMP is 17 Jan 2025, EDT 24/10/2025. Gestational age is 37. Previous delivery, she has delivered in the previous delivery. So she has had a male. She has delivered a male of 5 years. The interpregnancy interval is of 4 years. Her birth weight, the birth weight of the male was 2.8 kg. The male cried immediately after birth. The reason for past cesarean section was elective CS at 30 weeks for primary gravida with breech presentation. She was given spinal anesthesia. Penestrial incision was kept on the skin. Transverse incision was made in the lower segment of the uterus. There is no extension of the incision. Uterus closed in single layer in continuous non-interlocking manner. Then there is no post-operative complications noted. No history of there is no post-operative complications noted. No history of fever, discharge from wound site, or foul-smelling leukemia. Urinary catheter kept in situ for 24 hours. Urine passed after removal of catheter. Patient was discharged on day 7, and patient was the skin sutures were removed on day 10. The wound was healthy, and the patient did not opt for any contraceptive method.
Okay. Yeah, just sorry. Go back to the previous slide. So Tejas has very beautifully highlighted. One slide before. Can we go to the previous? Yeah. So this is, dear students. I mean, Tejas has beautifully highlighted everything in this slide. That what are, I mean, these are the factors actually which decide and which help us in decision whether we can take the patient for vaginal delivery VBAAC this time or she goes for elective cesarean section. So everything he has gone to details in this slide. So maybe Tejas can again highlight these points, like each point, because every point is an indication or not an indication of vaginal delivery or cesarean section.
Okay. Yes, sir. Sir, so during the examination of the patient, we need to ascertain for a few things. The first thing is that what is the type of C-section, whether the C-section was emergency or elective, because it is found that emergency LSCS has a poorer scar. Elective LSCS has a better scar apposition and better hemostasis and better scar integrity than emergency LSCS. So the first thing is it is an elective LSCS.
So if you take point-wise, like interval of 4 years, that is goes highly in favor, because if the interval is, what is the cutoff for interval, Tejas? When we need to do
months, 18 months, yeah, 1.5 years.
So she has a perfect interval of 4 years, which goes in favor of that we can try vaginal birth in this case. And birth weight, of course, is adequate. Child is absolutely fine. And then the indication of cesarean section. If the previous cesarean section was done instead of breech presentation is one of the best indications for repeat vaginal delivery, unless there is a recurrent breech. Really, can there be recurrent breech, Tejas?
Yes, sir. There can
in
be
this condition, there will be recurrent breech or transverse slide repeat.
Yes, sir. So, if there is a Mullerian abnormality, if there's a unicoordinate uterus, bicoordinate uterus, in all of these cases, there is a very high risk of recurrence.
Very good. So, if there is any uterine anomaly, septate uterus, unicoordinate uterus, and all that, so that may recur again. So, that is the in that. Otherwise, if it's like in your case, it's cephalic presentation, previous breech cesarean section for breech. So, these are one of the best indications for repeat vaginal delivery. Interval of 4 years is the perfect case for repeat vaginal delivery. and baby absolutely fine is a sign that, the baby healthy and weight was okay. And then, yeah, next spinal anesthesia, of course, that means absolutely normal. Financial incision, again, lower segment cesarean section, transverse incision. So all these are strongly in favor of repeat vaginal delivery. We can do, vaginal birth in this case rather than cesarean section. If it was a classical cesarean section or hysterectomy, then those are themselves indication for cesarean.
Repeat cesarean section.
Absolutely. So, and no extension of incision made, that also goes in favor. If the incision got extended, uterine artery got torn on one side, and sometimes we couldn't deliver the fetus through that incision. Rarely we extend the incision, and I have seen once we had to do a inverted T incision. Couldn't deliver the fetus through that, and then they had to make a vertical incision also on that. So that became like a classical cesarean. So those themselves will be indication for cesarean section rather than vaginal delivery. So no such thing in your case. And then uterus closed in single layer in continuous non-interlocking manner. You want to highlight about it if it was one layer or two layers?
Yes, sir. So there are two views here. The first one is that the single double layered closure is better than single layered closure in the terms of position, and therefore the scar integrity is better in the next cesarean section. But the recent study, which is the Coronis study, has pointed out that single layer, double layer, or locking, interlocking, or non-interlocking manner, none of these make a difference upon the integrity of the scar. Only two things make a difference on the integrity of the scar. One is perfect approximation, and the second is that if there is hemostasis achieved or not. Because if there is improper approximation or the hemostasis is not achieved, then there will be pockets of blood-filled spaces which will hamper the apposition of the scar. One, and the second, if there is any post-operative infection on it. But the number of layers of that we take, single or double, it does not affect the scar integrity.
Absolutely. So this is a very good Caesar trial, Coronis trial. Sorry, I was in fact part of it from India. So we did this case. A study was done on more than 16,000 patients in 8 countries, and 16,000 patients. So that, and then we followed these patients in subsequent pregnancies also. Okay, so it was not found to be that's whether you do single layer or double layer. There was no increased risk of rupture in either category. So that was one component of that. But some other studies did show that uterus closed in 2 layers is slightly better, but not proven by Coronis study, which is the single largest study published in Lancet. So that is a important feature. Yeah. Okay, you can go ahead then.
Yes, sir. Apart from that, first, if there is noted, if there was any history of fever or discharge from wound site or foul-smelling lochia, all of these will point towards infective sepsis infection, which is also which goes against deciding for a vaginal delivery. Then urinary catheter was kept in situ for 24 hours. If usually it is kept for 12 to 24 hours. If it is kept for beyond more than 24 hours, 5 days, 3 days, or 5 days, then one should anticipate that the call was taken for an obstructed labor, and which again goes against giving a vaginal delivery after cesarean section trial. Then the patient was discharged at 7th day and sutures removed on 10th day. The wound was healthy. Again, if there was a history where the wound...
Absolutely. So as Tejas said, I beautifully highlighted that, any infection in this, because that will make the scar weak. So that also may be an indication for cesarean section, but the patient had no post-operative complication. There were no discharge from the wound site, foul-smelling lochia. So that means patient did not have any peripheral sepsis, and there is no post-operative complication. If the wound got infected and all, then we can think theoretically that the scar may be weak, because not only the skin scar, uterine scar may also be weak. So that may be a factor. Again, urine catheter removed and patient passed urine. Patient was discharged home on adequate date, and no sutures were removed on time. So basically, everything goes in favor of VBAAC in this case. None of the complications are.
Yes, sir. So further, in the first trimester, spontaneous conception, pregnancy detected with UPT positive on 15th day of menses, missed period. No history of folic acid supplementation conceptually. The patient was started on tablet folic acid, 1 tablet once a day. There was no history of nausea, vomiting, or weakness, no urinary symptoms, no drug intake. Dating scan was done at 10 weeks using crown rump length, and NT scan was done at 12 weeks and was within normal limits. The second trimester, quickening was felt at 20 weeks. Patient was started on iron, folic acid, and calcium tablets. The patient was given 2 doses of diphtheria tetanus vaccine 4 weeks apart. An anomaly scan was done at 20 weeks and was found to be normal. Then the third trimester, fetal movements perceived by the patient, no leaking or bleeding per vaginum, no history of pain in abdomen, headache, blurring of vision, or epigastric. In the past history,
No,
there
sorry,
is no history.
sorry, just can you go back to the first and second trimester history again? Yeah. Okay, so that is very, you can still see how many patients are there who didn't take periconceptional or preconceptional folic acid. So just want to highlight to all dear students here that please, you have your relatives, you have your sisters, brothers, wives, etc., and cousins. So do ensure that every single patient should conceive on periconceptional folic acid. Folic acid is such a safe tablet, vitamin B11 only. So totally safe, so they should take it. And, because by that time neural tube is already found, by that time we detect them to be pregnant. And then again, and it's a routine that, dating scan in first trimester, usually 8 to 10 weeks, is the single most important scan from which why it is so important, Tejas, dating scan?
Sir, it is that is the best indicator of the gestational age using crown rump length. So it helps to if the mother is not sure about her dates, and if the dating history is not excellent, then in that case, we using the crown rump length, we can easily determine what is the gestational age so that we don't underdate or overdate the patient.
Absolutely. So the first trimester scan is the best scan, most accurate, and it is less than within plus minus 1 weeks is the accuracy. If you do it in second trimester, it is plus minus 2 weeks accuracy. If you do it the third trimester, it's plus minus 3 weeks. That means a scan done at 33, 34 weeks can be 3 weeks wrong on this side or that side. While in second trimester can be 2 weeks wrong. While first trimester scan is usually within a week, it is right. And Tejas, suppose you did dating scan and at 10 weeks, but it showed it to be 12 weeks versus it showed up to be 10.5 weeks. Will you change the dates?
I'm sorry, sir.
Like at 10 weeks, ultrasound was done and crown rump length showed it to be 12 weeks. So now will you change the date of expected date of delivery and LMP? 2 weeks discrepancy in the first trimester scan?
Sir, 2 weeks discrepancy in the first trimester scan, according to me, is very significant because the margin of error is 5 to 7 days only. So therefore, we will have to give a corrected LMP, corrected EDD to this patient.
Yeah, so we need to change the dates, isn't it?
Yes.
But if it is just 10 weeks, but showing 10 week 4 days or 10 week 5 days, will you change the dates?
Yes, sir. No, so 5 to 7.
So it has to be more than 1 week.
7 days we can give.
The discrepancy has to be more than 1 week. Okay, then only we change the dates because up to 1 week error can be there in the first trimester scan also. So if it is the discrepancy is more than 1 week, then only we change the date. So that's why dating scan is extremely crucial because many times patients don't remember their dates. They may be mistaken dates, and this is crucial to calculate the expected date of delivery because later on we may decide when to induce patient. Like diabetic patient we may induce at 38 weeks, ICP patient we may induce at 37 or 36 weeks. So absolute maturity calculation from the first trimester scanning absolutely crucial to make obstetric decisions later on about time of doing cesarean section, time of whether we need to do dexamethasone or not, and whether we need to do elective cesarean section at what gestation. And thirdly, all other tests like when you are doing NTNB scan will also be dependent on that. Then if you are doing a dual marker, they also will be dependent on that. So everything is calculated from the first trimester scan. Yeah, because that is the most accurate. So that is why this very common question asked in exam. So that's why those were not related to first trimester for previous cesarean section. I just want to highlight this important point. It will be suitable for every single obstetric case. And NT-NB scan, you can call it, done at 12 weeks was within normal limit because what is the importance of NT-NB scan? Nasal thickness and nasal bone.
Sir, NT and NB, both of them are soft nuchal translucency and the nasal bone. Both of them are soft markers for trisomy 21 Down syndrome and even for other trisomies. And apart from that, majority of CNS abnormalities, for example, anencephaly can or myelocele, can be diagnosed as early as the 12 weeks up to 13 weeks.
Very
So
good.
therefore, and if the CRL has not been measured using the dating scan, then the NT scan becomes the second best measure for giving accurate gestation.
Absolutely, absolutely. So it is a mandatory to do NT-NB scan, and we call it nuchal thickness nasal bone scan. Nasal bone should be visible for a normal pregnancy, and nuchal thickness should not be more. If the nuchal thickness is more, because in Down syndrome, there is nuchal thickness increases. Same in nasal bone, it may be absent in case of Down syndrome. So they are markers for Down syndrome, and but from them you can't make the diagnosis of Down syndrome. They are screening method. That means patient is at high risk, and that will be an indication for doing further definitive test, which is
either chorionic villus sampling or amniocentesis.
absolutely either CVS or amniocentesis, not NIPT. NIPT is not a definitive test. That is also just one of the screening methods. So instead of NT-NB and dual marker, you can do NIPT also. It has got higher sensitivity. But if the test is any test is positive, then don't do NIPT. NIPT is also a screening method with higher sensitivity. So that should be clear that, and don't do NIPT for confirmation of diagnosis. Confirmation of diagnosis is always by either CVS or by amniocentesis. And did your patient have, next slide please, did she have dual marker?
No, sir, dual marker was not done for this patient.
Dual marker was not. So normally in Delhi and in all, like in AIMS and all the hospital, routinely in the hospital I'm working, so we are routinely doing dual marker for all patients at 11 to 13 week scan is very crucial, and TNB scan plus dual marker at this gestation. We are doing it. So if the dual marker screening it shows low risk and TNB scan is normal, no further testing is done for Down syndrome. But the either nasal thickness is nuchal thickness is more, nasal bone is absent, or dual marker shows high risk. The report will not. There are no absolute values of taken of dual markers, but the value shows it to be high risk for Down syndrome. That doesn't mean patient has got Down syndrome, but that means patient sensitivity is positive. Like, patient is screened positive for Down syndrome. So we need to do definitive test either CVS or amniocentesis to confirm. So that is the importance of that. And instead you can do NIPT also if the patient is say 35-year-old or more. Some people are routinely doing NIPT that has got higher sensitivity. And if that is negative, I mean not normal low risk, then no need to do amnio. But if NIPT also shows high risk, then also we need to do amniocentesis or CVS to confirm. That is the important. But I am seeing some people are doing NT-NB also, dual marker also, NIPT also. No. If you are doing NIPT, then there is no need to do dual marker. I suppose patient missed dual marker and patient comes to you at 15 to 16 weeks of pregnancy, then what will you do?
Sir, we can 15 weeks triple marker or quadruple marker.
Yeah, then you can better do quadruple marker. Triple test is not done these days. It has got a lower sensitivity. So quadruple test to be done in that. And then you, okay. And now you have mentioned patient was started IFA and calcium tablets. And you said patient was given 2 doses of DT vaccine 4 weeks apart. So what is this DT, not TT? And what is the logic of that? And is it DT or sometimes can we give Tdap also?
Yes, sir. Tdap, that is diphtheria, tetanus, and acellular pertussis, that can also be given. But the government regimen now is that we give, at this moment in our setup is diphtheria and tetanus toxoid vaccine. It is given 4 weeks apart, and the logic is that it provides antibody protection towards tetanus, maternal and neonatal, and it also provides antibody protection towards the infection of diphtheria. So both of them can be taken into the same vaccine.
Okay. So till about 5 to 10 years back, we were giving TT. When I did my MD or SRC for even young faculty, we always gave only TT vaccine. And if the patient had received TT vaccine within last 5 years, then we gave only single dose of TT. And now that remains same. If the patient received the last week, the only single dose to be given, but not otherwise 2 doses to be given. But it is like, now, someone is saying TT. Yeah, this is not, we shouldn't call it DT. I mean, when you are giving to a baby, then we call it DPT. Okay. diphtheria, pertussis, tetanus, because it has got higher dose of diphtheria and pertussis and tetanus, But when you are giving in pregnancy, mainly we are giving tetanus dose. Okay, but it has been seen that has been a lowered immunity for diphtheria and pertussis also, and waning immunity. So there have been cases reported from Rajasthan of diphtheria returns to Rajasthan and like that. So and waning immunity is there. So now they are saying that pregnant woman is also at risk, but the dose of diphtheria and acellular pertussis is much lower. So you can't use the term. Don't use the term DPT or DT. Okay, T should come first because it is essentially T. We are giving lesser dose of diphtheria and lesser dose of acellular pertussis. So the name should be Tdap or TD, not DT. Okay, some students also had mentioned that. And you can, like, Postgraduate is one such vaccine, no? And we give acellular pertussis because pertussis is a nasty vaccine which causes a lot of side effects. When you are in DPT also, it's the whole cell pertussis used to cause more side effects. No, now we are using the acellular pertussis, but even that can cause more side effects. So we use the term either TD or you use or Tdap you use. So mainly tetanus, but lesser dose of diphtheria, lesser dose of acellular pertussis is to be given. So that is the concept coming. But unfortunately, patient has to buy it because most of the government hospital are not having it. I mean, if the patient is free, the patient gets it free of cost, then it is TT only. If the patient wants Tdap, then usually they have to buy it. Available as Postgraduate injection, one of the good company, then they have to buy it. So that is what we used to do in AIMS. If the patient was able to buy it, or sometimes in CHS they get it, then we would give Tdap or Postgraduate, otherwise TT. So diphtheria pertussis are very rare, but can you? Someone asking the clarified number of doses. So usually, if the patient has received TT vaccine in last 5 years, then we give single dose of TT at usually any time between 14 to 20 weeks of pregnancy. If the patient has not received TT in last 5 years, then we give 2 doses of, and these days we are giving Tdap as inside. So first dose can be given at 14 to 18 weeks of pregnancy. Second dose after 4 to 6 weeks of that. And we give Tdap or Postgraduate injection these days. But you can give TT also because diphtheria pertussis are exceedingly rare. But yes, can happen to it. But TT is a must. Okay, so you can continue, Tejas.
Third trimester, fetal movements perceived, no leaking of bleeding PV, and no history of pain in the abdomen, headache, blurring of vision or epigastric. Then past history, there is
there
no
only you should say about pain in the lower abdomen also at scar site somewhere, no?
Yes.
Because see the previous cesarean section, because then it can be evidence of scar days and so forth.
Yes. In the past history, no history of tuberculosis, epilepsy, or asthma. She is not a known case of diabetes mellitus or hypertension. She does not have any history of previous surgeries apart from cesarean section, and there is no history of blood transfusions.
Okay, very good.
In the family history, there is no family history of congenital anomalies or twinning, hypertension, diabetes mellitus, tuberculosis, bleeding disorders, or any known genetic disorders. Personal history.
Okay, fine.
Contraceptive history. There is no history of using any contraceptive methods. In the personal history, her diet is mixed, her appetite is good, her sleep is sound, bowel and bladder habits are regular, and there is no addiction. General examination. The patient is conscious and oriented to time, place, and person. She is well built and well nourished. Her pulse is 84 per minute, regular with a good volume. BP is 110 by 70 millimeters of mercury in the right arm in supine position. Respiratory rate is 14 per minute, regular. Temperature afebrile. Height 155 centimeter. Pre-pregnancy weight 50 kg. Present weight 60 kg. Her weight gain is 10 kgs. BMI is 21 kg per meter square. She has lower palpable conjunctiva pallor present. She does not have icterus, cyanosis, clubbing, edema, lymphadenopathy. Her spine is normal. And pedal edema is noted on the bilateral feet up to the middle of the shin, and it is of the pitting type.
So is it physiological?
Sir, on clinical examination, it is not physiological because it should not be up to the level of shin. But on history, it is revealed that when she rests, the edema resolves on its own. So, and the BP is normal. So, at this moment, she has not been diagnosed with pre-eclampsia. From head to toe examination, the head has normal, no frontal bossing. Hair, Normal distribution black in color. Scalp clear with no dandruff. Nails normal healthy. Face normal, chloasma gravidarum present. No maxillary prominence. No facial puffiness. Eyes vision is normal. Sclera and conjunctiva normal. Pupils are reactive to light. Ears are symmetrical. Absence of discharges. Hearing is normal. Nose symmetrical. Nasal normal septum. No discharges present. Oral cavity normal distribution of teeth. Absence of dental caries, absence of halitosis, tongue is coated. Neck, normal range of motion, absence of lymph nodes and lymph node enlargement, and absence of thyroid gland enlargement. Chest has symmetrical expansion of chest with no scars noted. The breast and nipples slightly enlarged. There is slight white discharge from the nipple, and nipple is normal without any retraction or inversion. The skin, linea nigra, is present, stria gravidarum is present, chloasma gravidarum is present, and in extremities, upper and lower extremities have normal range of motion. Cardiovascular system, S1, S2 is heard, no murmur. Respiratory system, normal vesicular breath sounds are heard, bilateral air entry is equal with no crepitations. And CNS, higher functions are normal with normal gait and balance.
Okay, just a minute here. So, sorry, go back to the previous slide. Okay. Yeah, so Tejas has very beautifully highlighted all the system in complete details, but that is, we have discussed it before also in the cardiac patient. So, if a patient is normal, we just mention S1, S2 heard, no murmur. Same with bilateral vesicular breathing all over the chest without any accompaniment. But if you get a case of cardiac disease like mitral valve, mitral stenosis with pregnancy cardiac disease, then you have to give complete details. Similarly, patient has got some pulmonary disease, then you have to mention the complete details of respiratory chest, in inspection, palpation, auscultation, percussion, like that. Otherwise, this much is good.
Yes. Obstetric examination. On inspection, abdomen is uniformly distended, globular in shape. There is no abdominal wall edema. Umbilicus is normal and flushed with skin. Hernial orifices are normal. Flanks do not appear to be full. No apparent hepatosplenomegaly. Stria gravidarum and linea nigra are present. And there's a phalansteal incision of 10 centimeters noted, which is healthy and has healed with primary intention.
Yeah, very good. So this is very, very crucial. Go back that healed with, you have to mention about the scar. So it is a 10 centimeter transverse this scar, which is healthy and has healed with primary intention. How do you know it is healed with primary intention, not secondary intention? Can you tell us from the site of by looking at the scar? Or...
Yes, sir. So the first thing we have to ask is that in the history, if there is any history of any wound gape or resuturing which has been done for this patient, which is not there in this patient. And second, on examination, we find that the primary, when it heals with primary intention, the scar is linear, uniform, and it does not have any formation of keloid or keloid or any hypertrophied scar. Whereas if it is healed with secondary intention, it will be non-uniform. It will not be linear. It might not be linear, and there might be presence of keloid or a hypertrophic scar.
Absolutely. That is very, very crucial because that will be deciding factor for us also in a way whether we should go for normal delivery or cesarean section. Those skin scar may not be that much relevant, but it goes a little bit if there has been infection in the skin scar, there may have been infection in the uterine scar also. So that might have made the uterine scar weak, and theoretically we may be tilting toward doing cesarean section than vaginal delivery. So that's why it's the importance. Next slide.
Yes. Then palpation. The symphysiofundal height is 38 centimeters. Fundal grip shows a soft, broad, and non-palatable mass, suggestive of breech. Lateral grip shows knob-like structures on right side, suggestive of limb buds, and uniform resistance on the left side, suggestive of spine. The first pelvic grip shows a smooth, hard, palatable mass, suggestive of head, and the second pelvic grip shows the fingers converging, which indicates the head is not engaged. The uterus on palpation is relaxed, and there is no scar tenderness noted.
Oh, yes. So how did you look for scar tenderness?
Sir, we stand on the right side of the patient. Then with our dominant hand, we put the hand on the scar and palpate the scar. And at the same time, we have a conversation with the patient such that we take the patient's attention away from what we are doing. While doing the palpation over the scar, if the patient winces or shows any signs of pain at the scar site, then that shows that the scar tenderness is positive. But the prerequisite is that the uterus has to be relaxed and not acting. Even during labor, if you're trying to test for scar tenderness, then it should be done in between two contractions and not during contraction.
If the patient had a, the cesarean section has been done by vertical incision. I mean, infraumbilical vertical incision, then where do you look? Will you look for scar tenderness?
Sir, most likely the uterine scar would still be lower segment transverse. So therefore, we will look at the same site as we are looking for a phalansteal incision, which is
So
in the
this should
lower
be
segment.
very, very clear. Quite often in the exam, I have gone as the examiner. So students make this mistake, mostly undergraduate, final students, not PGs, but they have made this mistake. Say, look for the scar tenderness. So he was looking on the vertical scar on the skin scar. So the students, I mean, may look very simple question, but people have made mistakes on that. So it is not the skin scar we are interested in. We are interested in the uterine scar, which is always lower segment transverse incision. Even if it is vertical incision on the skin, the skin scar, uterine scar is transverse. So you still need to fill the suprapubic area, as Tejas had highlighted, and as he beautifully highlighted, make the patient ask her, okay, what is your name? Where do you come from? Oh, you come from Badurgad, whatever name. Oh, that is the weather is good there and all. So divert her mind. Otherwise, invariably, I have seen it. If you straightway put your finger on the suprapubic area, all the patients have some pain at time, and then you falsely think that patient has got scar tenderness when she does not have it. So that is very, very important, and especially viscera. But of course, if it is a classical incision, classical cesarean section these days, in fact, I have done two recently of placenta in Creta patients. In that case, uterine scar is also vertical, so then you have to look in that. So for that, you will invariably have the finding that patient had classical cesarean section for this thing. Of course, in those patients, I had to do hysterectomy. So there won't be any scar on the uterus now. But if you do classical cesarean for some indication, rarely, and uterus has been saved, then usually we tend to do ligation in the same sitting. So less likely that such patient will come with repeat pregnancy. But if the baby did not, baby died or kissed, sometimes we may not do ligation for some patients. So then you have to do see in the upper segment vertical incision, same as the skin, not otherwise. But that is exceedingly rare. In exam, you'll always get, even if it's these days, all the incisions are usually transverse only, no skin also. So then they correlate to each other. But even if it's a vertical incision, the skin scar, uterine scar will still be transverse, as Tejas has said. Okay, thank you. Tejas, go on.
Yes, sir. Then on auscultation, fetal heart sounds are heard along the left spino-umbilical line. The fetal heart is 142 beats per minute. It is regular and rhythmic. Then we proceed towards local examination of external genitalia. There is no vulvar edema. The per speculum examination, cervix and vagina are healthy, and there is no leaking or bleeding per vaginum. And per vaginal examination, the cervix is non-dilated and non-effaced. So the provisional diagnosis that we make is 24-year-old female with 37 weeks, 0 days of pregnancy. In the case of second gravida, with post-cesarean section pregnancy, with single live intrauterine fetus in cephalic presentation, not in labor.
Go back to the previous slide. Okay. So here, when you had done vaginal examination at 37 weeks, shouldn't you do pelvic assessment also?
Yes, sir. Pelvic assessment, yes, sir, should have been done. In this case, of course, the pelvic examination showed that the pelvis is adequate. All the parameters from the inlet to the outlet were assessed: the sacral promontory, the curve of the sacrum, and the ischial spine, as well as the outlet with the knuckles were assessed, and it was found to be adequate for vaginal delivery.
Absolutely. So for such case, because she had not delivered vaginally, we had a cesarean section. So we need to do pelvic assessment for this patient at 37 weeks, and then we need to decide. So as they just said, pelvic assessment has been done for her, and pelvis is normal. But cervix is non-dilated and non-effaced. So okay, it doesn't admit even tip of finger. So that goes little bit. Yes. So now go back to the diagnosis again. Okay. Yeah. So 24-year-old, 37. Maybe with with previous cesarean section, cesarean. Okay. Maybe somewhere we can, write for breech presentation, because that is a 20th share of, vaginal delivery. So how will you manage this patient now?
Yes, sir. So she has come for a routine antenatal checkup. We will do a routine checkup for this patient, and we will call her on a weekly basis for routine antenatal checkup till 39 weeks of gestation. Our institutional setup is such that we take previous cesarean section up to 40 weeks of gestation. At 40 weeks of gestation, we assess if the patient has any contraction or has gone into or is showing any signs of labor or not. If she is not showing any signs of labor till 40 completed weeks, then in that case, we will take her up for an elective repeat cesarean section. Otherwise, we will allow her to progress into a normal through a vaginal delivery. That is, we'll give a trial of labor after cesarean section. So till she has spontaneous contractions, till then we will call her on a weekly basis to the OPD, and we will do a weekly CTG and NST monitoring for this patient, and a USG will be done for this patient at 38 completed weeks, and after that at 40 completed weeks we will reassess this patient for labor. Once this patient goes into labor at 40 completed before 40 completed weeks, then we will the first thing is we reassess the patient for her any contraindications toward vaginal delivery. For example, if there is any pelvic, if we see that there is a cephalopelvic disproportion in this pregnancy or not. If not, then we allow her to go into the first stage. In the first stage, we admit the patient to the LR and we maintain a partograph for the patient. We will we keep in our setup we keep the patient nil per oral, and we only give her IV fluids and if required soft diets. Otherwise, we will always keep her ready for a requirement of C-section. And we will also do a fetal heart monitoring. In this case, electronic fetal heart monitoring will be done. If electronic fetal heart monitoring is not available, then fetal heart rate will be heard for every 15 minutes through intermittent auscultation. And PVA, per vaginal examination, will be done every 4 hours. Apart from that, a senior obstetrician will be involved in the case, and anesthetist will be informed so that immediate emergency cesarean section can be taken at any point of time, along with intimation to the pediatrician so that she can be or he can be available for this patient. Then, once the patient goes into the second stage of labor, we have to cut short the second stage of labor so that we, in the sense that it should not prolong beyond 1 hour. If it goes beyond 1 hour, that is, if there is a prolonged, if we are seeing that the second stage of labor is not progressing, then instead of allowing her to go into a vaginal birth after cesarean section, we should take her up for an emergency cesarean section in view of that, because excessive prolonged second stage of labor can also be a high risk factor for uterine rupture. Apart from that, in the third, we will, in our setup, we do not use instrumental delivery for a patient of vaginal birth after cesarean section. We only allow her to go into a spontaneous progress of labor. And after the delivery is done, the third stage of labor, in the third stage, active management is done as is done for any normal vaginal delivery with injection oxytocin and uterine tone assessment, along with removal of placenta using the pull and the that which is done for active management of third stage of labor. And after doing the active management, we have to see how once the placenta gets delivered, the placenta needs to be assessed. If the placental bits, part of the placental bit is absent in this patient, and if it requires any further assessment, then a USG-led assessment should be done to identify if there is any placental bit left inside the uterus or not. And one thing which can be done, controversial, is that the assessment of the uterine, the incision of the previous scar, uterine scar, using digital exploration, if it has to be done after normal delivery or not. At our setup, we do not do any vaginal examination to assess the uterine scar after the vaginal delivery.
It was in vogue. It was in vogue many years, 10 to 20 years back, but nobody does it anymore, because I mean you cannot really assess it very well. And secondly, sometimes by your own finger, we may actually ourselves, cause harm to that area. So usually not recommended. But how will you know? Is there a method clinically? Will you be able to know if the scar has given way while you are? I mean, you are doing VBAAC or TOLAC after the term. You want to tell them a little bit about VBAAC and TOLAC? How do they?
Yes, sir. TOLAC is trial of labor after cesarean section. As we that is a decision that the obstetrician makes to give a trial of labor in his patient who has had a previous cesarean delivery, and only after a successful TOLAC, the birth happens through vaginal route. That is known as VBAAC, vaginal birth after cesarean section. We might consider going for a TOLAC, and during the process of TOLAC, we might think of going for an emergency cesarean section. Then that TOLAC has not led to a VBAAC. It has led to an emergency repeat cesarean section. So a TOLAC is trial of labor, whereas it can either go into an emergency cesarean section or into a VBAAC. And while giving a trial of labor, the signs and symptoms that we had to look for so that we rule out any scar dehiscence or scar rupture. The first thing is that intermittent assessment, palpation of the uterus so that we rule out any scar tenderness. Then once there is scar dehiscence or a scar rupture, when there is scar dehiscence, one of the first signs is that there will be fetal heart rate abnormalities, particularly
Absolutely. So
fetal
that is a common
tachycardia.
question asked in exam. The first sign of scar dehiscence, usually.
Yes, sir. So fetal tachycardia, it is followed by maternal tachycardia. If fetal and maternal tachycardia are missed, then the scar dehiscence can convert into a scar rupture. And during scar dehiscence, there will be maternal tachycardia. But once there is scar rupture, then because of the internal bleeding, the patient will ultimately go into shock. So scar dehiscence presents with maternal tachycardia, whereas scar rupture presents with maternal shock. Apart from that, the patient will complain or give a history that she had abdominal pain and she was in labor, and suddenly there was stoppage of any abdominal pain or cessation of any pain in the abdomen, because as soon as the uterus ruptures, there is a cessation of labor pains. Apart from that, the patient will present in shock, and on PV examination will be a loss of the pole. That is, if the head was engaged earlier, on examination further, we find that the head is seen to be floating or higher up, or the station moves up. That is another indication of a fetal uterine rupture. And when we do the fetal examination, we find that the fetal heart often than not would be absent, because sudden uterine rupture can lead to fetal.
Any bleeding from vagina or any hemorrhagic urine, will that give you some clue?
Yes, sir. If there is a sudden gush of blood that is bleeding from vagina, or if you have catheterized the patient, which should be done in the first stage of labor, and if there is gross hematuria, then both of these indicate that the patient might be uterine rupture or an imminent uterine rupture.
Okay. So, and these patients should not be induced, they should not be augmented. You have already highlighted that. Okay, so either they go into labor of their own, and otherwise we do elective cesarean for them. Okay, now, so suppose we are doing elective cesarean for her, like patient did not go into labor, Tejas, and it's 40 weeks, and then you plan that you want to do cesarean section. Or sometimes patient, you never mentioned that. I will discuss with the patient. Did you? Maybe I missed it. We have to, because with the previous cesarean section, the patient can also demand elective cesarean section, routine elective cesarean section. What will you do in that case? Cesarean section on demand for such patient. So, I mean, if the patient demands, otherwise also even in primary gravida, we have to do cesarean section, the patient demand. So, cesarean section on demand is becoming an important issue these days. But in previous cesarean section, many patients are actually demanding cesarean. So, then we can't refuse it to them. We can only advise them. We can only give pro and cons of both techniques, and the risks of having repeat cesarean sections. So that is very important. And then Tejas, okay. So yes, I mean, the patient wants cesarean section on demand. We have to do cesarean section on demand in such patient, because there is some indication of doing cesarean being previous cesarean. So we can't refuse it to them. Tejas, are you there? Dr. Aditya?
Sir, I think his network has been just
Okay, okay.
disconnected.
So maybe you
Uh,
can just you
yes,
can
I would
sum up
want to
and you
answer.
can
Could you
tell
just
a little bit.
repeat the question, the entire question?
Okay. So you like suppose uh, that I think he answered the question and people heard it. No, the patient does not go into labor. Then TJ, we have to do cesarean section. The question was if the patient demands cesarean on demand in such a case with previous cesarean, then what should we do?
So first of all, whenever a patient is demanding an elective cesarean section and a cesarean section on demand, the first thing that we should be telling them is the exact weeks of gestation that we'll do it at. So that is the first thing that we have to tell them, that it cannot be done before 39 weeks of gestation, and unless she goes in labor prior to that. So that is the first thing that I'll tell them. Apart from that, I'll take a proper consent. I'll explain to them that if the fear of pain is one of the reasons why you would want to go for an elective cesarean, then in that case, we have the option of taking ahead labor analgesia like epidural. That is, in fact, one of the things that they see on social media and from their own peers telling them that vaginal delivery was so painful and they had episiotomy that was painful. So we can tell them that episiotomy is not the norm. Pain is definitely not the norm. We have several options like epidural and a lot of labor analgesia modes that can reduce their pain. And if they're still not ready, then we can tell them about the complications that they have to expect. The increased complications, maternal complications like the injuries, bowel bladder injuries, post-operative complications, and also the neonatal problems like transient tachypnea of newborn and long-term respiratory disorders that these
Yeah,
fetuses
that
tend
should
to
be
have.
fine. So, Dr. Aditya, maybe here only you can highlight. Suppose we are doing a repeat cesarean section for this patient now, and she did not go to labor. So, what problems we can ensure while doing a repeat cesarean section in this case versus you are doing a primary cesarean? So, I mean,
Okay.
second cesarean section, what problem? That is a very important question asked in the exam. So, student will be benefited starting from the skin, uterus, and
Yes, sir.
all the complications.
So the various dilemmas at various levels, I would want to highlight them. So the first dilemma is going to be the incision. In a lot of peripheral centers, a vertical midline incision is still being taken as the norm, whereas in all the tertiary centers and in the metropolitan cities, it has now compulsorily become a phalansteal incision. So the first discussion is going to be on what is the incision that we would want to take. And of course, cosmesis is a major thing nowadays. So we have to tell the patient when do we intend to take a vertical midline incision versus a phalansteal incision. We have to tell them that if I'm going to take a vertical midline, because the previous was vertical midline, there is a 50% chance of having adhesions. Whereas if it's a phalansteal incision, there are only 25% chances of previous adhesions. So depending on the previous scar, my current scar and current incision is going to be determined. Secondly, whenever I'm opening the skin, whenever I'm opening all the abdominal layers, after that, there are chances of adhesions that are not going to be there in the primary gravidas like sheath and muscle. Between the rectus sheath and the rectus muscle, there will be adhesions. While doing this adhesiolysis, I may have to even take something like a Maillard's incision, which is a muscle cutting incision so as to bypass the adhesions. And that can be an incision which can lead to the injuries to the inferior epigastric vessels, that can lead to even injuries to the perforators in the rectus muscle. So there is a higher chance of blood loss and the need for blood and blood products intraoperatively in a previous cesarean section. Then when I reach the layer of peritoneum, there can be adhesions between the parietal peritoneum and the uterus, and also between the omentum, bowel adhesions, and the anterior abdominal wall adhesions with the uterus, which I will need to do adhesiolysis for. That adhesiolysis might end up also injuring the bladder and bowel, which is something that is an inadvertent injury that can happen, which might require the creation of a stoma or might even require prolonged catheterization or bladder repair. And these are all the complications that also increase the stay in that
So, how to
hospital.
avoid bladder injury while you
Okay,
are
so
pushing the blood?
yes, sir. So how to avoid bladder injury? The first thing is when we open the peritoneum with one finger, we can actually first go and see if the bladder is roughly advanced or not. If I know, if with my finger that the bladder is not advanced, then I can just go ahead and continue my cesarean section. But if I believe or if I see or I feel that the bladder is completely advanced, then the first thing that I would want to do is after opening the parietal peritoneum, I would try to get a plane of the loose UV fold so that I can try doing sharp adhesiolysis and trying to push the bladder
Absolutely.
downwards.
So, this is what I want to add. So, this is sharp dissection should be done, not blunt dissection.
Blunt
While we are
dissection,
pushing with the blunt dissection, that is the time when bladder gets opened
when
because
bladder
it is
mucosa can be
adherent.
opened up. Yes.
And
So
suppose
blunt
bladder
dissection.
got opened inadvertently, what will you do?
So if the bladder has been opened up inadvertently, the first thing that I would personally want to do is I would want to hold the edges with a Babcock's forceps. Now, because the patient is under anesthesia, my priority is going to be to first deliver the baby so that or general anesthetic drugs will not lead to any fetal depression. So once the fetus is delivered and once the uterine incision is closed, because that uterine incision can also bleed a lot, after that, I will be repairing the bladder. So whenever I repair the bladder, the first thing that I have to understand is a multi-layered closure is very important. At least a two-layer closure is required for the mucosa and the
With
serosa.
with suture.
Sir, I would want to prefer a suture like 2030 Vicryl. I would want to prefer that
Yeah, we
and a
use
lot,
usually 30 Vicryl, but
yeah,
20 Vicryl
30.
can also be used, and
Yeah,
minimum
depending on
2
the
layers.
availability. But 30 is a good
Will you
one.
do it yourself, or should we call the urologist for surgery?
Sir, ideally, if you are working in a tertiary care center, then it is always ideal on a medical legal way to call upon a urologist. Although a gynecologist, if trained well enough or in a peripheral center, and if they have to wait for too long for the urologist to
Yeah,
come to
I
their
think
OT,
in
they can do it.
exam, no, whenever there is bowel injury or this thing for the students, they should answer. Even if I'm doing it, I'll do it under
I'll at least
supervision
call
of
them
it.
for
So we'll call,
supervision,
and they should have shared responsibility. Their name will be written in the notes for medical legal reasons.
medical
So
legal issues.
they have to.
Yes.
Yes.
And then I will repair the bladder. A primary closure can be done. Depending on what the urologist prefer, we can also put up a suprapubic catheter if they deem that it is to be put. If the injury was near the trigone, they often prefer to put a suprapubic catheter, and they also prefer to do a ureteric catheterization if the injury has been near the trigone. So depending on the area of injury, it will depend on how is the closure that is being done. And then after that, I'll do the uterine closure since it is a previous cesarean section. In our case, a lot of people prefer to do resection of the edges of the uterus so that the healing is going to be better. So it's a thing that is more so based on what the experience and what is the opinion of that obstetrician. And once that is done, we'll again close the layers. Each layer will be closed. And finally, if the skin is fibrosed, if there is a keloid, we will preferably do a keloid or the scar resection. Refreshing of the edges will be done. And then we'll close the skin.
And we should encourage the patient, of course, after consent to do for ligation if the second baby alignment.
Absolutely, yes. So
We should
contraceptive method have to
encourage
be
them
advised.
to do ligation. Of course, with their permission and with the consent. So, and post-op caring. I think we have covered everything. Maybe Dr. Aditya, you can just finish it off everything. And if any students have asked any question, otherwise you can just giving the finishing touch.
So first of all, you have ensured that we have covered every single question that could have been asked in this topic. So first of all, thank you so much for that. And sir, it is only fitting enough that you are the one who gives a final word on this topic, given that you must have done a record number of cesarean sections in your career. So we would love if you could just give one final word that as a clinician, what should be that one care that all the residents should be taking whenever they are doing a cesarean section, be it a primary or a repeat cesarean section, and so that the subsequent cesarean section, whenever it is done 2, 3 years later, it's a good cesarean section, it's a clean cesarean section. So, what are the precautions that you would take as an experienced clinician in this cesarean section to avoid these complications in the subsequent cesarean? What are your views, sir?
Okay. Yeah, thank you, Aditya, for that. Yeah, that is very, very crucial. Like quite often in India, we used to get patients. I mean, to the cesarean section was done in Bihar with all apologies. I mean, I have nothing against Bihar doctors, but the cesarean done were in a poor shape in a way. They were always vertical incision, and they had usually healed by secondary intention, as they just had highlighted. So usually we used to take them that that scar is not going to be very good strong. So that is very important. So that's why it's the primary cesarean section. If it is done properly, suitably. So while doing primary cesarean section, the incision we should do it at about 38 weeks of gestation electively. And then while doing it, the cesarean section, we should respect the tissues. We should cut skin, subcutaneous tissue, rectus sheath, and then you can do by blunt, but usually sharp dissection is better. Open the peritoneum and then the uterus lower segments incision. First open the uterocycle pouch, gently push the bladder down, and many times we avoid pushing too much of the bladder in first time itself, no? Because that can also cause. And then we make a transverse incision. We can increase the incision on either side with the scissors or sometimes with the finger also blunt. And then after delivering the fetus, have adequate incision on the uterine scar. Never give less than 10 centimeter incision because the fetal head is 10 centimeter broad, no, at 9 point, more than 10, 9.5. And it is that time actually. Sometimes I have seen people giving only 9 centimeter incision. So how can you deliver 9.5 centimeter to 9 centimeter? And then the extension occurs. And extension occurs into one of the uterine arteries on one side. And then when you are trying to repair that, it is bleeding profusely. But sometimes blindly stitches are taken and the ureter can get compromised. So that's why it is very, very important to give a adequate incision of 10 centimeter minimum, and then deliver. We can put the end below the head, and if the head is deeply impacted, second stage cesarean section or deep transverse rest, then it becomes very, very important and difficult. All the more. So in that case, we have to be very careful about the extension of that. So, and then after delivery of the fetus, we need to see the uterus in this case, like she had a breach presented. So we can look for any uterine anomaly, septum, etc. Tejas has said. And then remove the placenta, ensure that uterus is empty and it's not bleeding. Sometimes the placental site also bleeds. And then we, after delivery of the placenta, we ensure that cervix is also open. Sometimes we can use the finger to dilate it, otherwise patient can have lociometra. So that's not a must mandatory. And then we stitch the uterus in 2 layers. Don't stitch the endometrium. Stitch the inner 2/3 of the myometrium in first layer with the number 1 vicryl or sometimes 10 vicryl. Don't use catgut anymore, but vicryl should be used. And then second layer we do with the number 10, number 1 vicryl. And sometimes with the same stitch you can do it also, one stitch, but usually 2 stitches are required. And ensure that we have taken angles. And you can catch the angle with either with green armitage forceps or 4 Ellis forceps are more commonly used these days. If any area is bleeding, we can put green armitage forceps at that level. So we nicely close it, and peritoneum is not closed these days. Okay, the studies have proven that closure of peritoneum is of no use and doesn't prevent adhesion. And then rectal, we just ensure the cleaning the cavity properly, peritoneal cavity, any blood clots, etc. are removed. And then we close the abdomen. Muscles are not to be taken. Abdominal peritoneum is also not closed, but some people close it with white catgut also. And then rectus sheath has to be closed properly. And it is like either if in a transverse incision, we do it number 1 vicryl, and in a vertical incision has to be done with the proline or nylon non-absorbable stitch. That should be very clear. Vertical incision always non-absorbable, transverse incision number 1 vicryl. In transverse also, the weak scar you are suspecting will be cesarean, you can use proline also in that case. But usually number 1 vicryl, and vertical incision proline or nylon. And then skin incision, you can no need to close the subcutaneous tissue or fat unless it is very thick. If the thickness is more than 5 mm, then you have to close that also. So that is what we do. And then skin, it can be done either way. Subcuticular stitches are best if possible in the case, but with the repeat cesarean section, or if you are not happy with the hemostasis, then don't use subcuticular stitches. In that case, you can use staple, you can use interrupted stitches. So all the 3 methods can be used. Subcuticular are the best if possible, but you have to have complete hemostasis, preferably first cesarean. Repeat cesarean section, I mean, sometimes you may not be, and you have to do the subcutaneous fat in that case, if you are doing subcuticular stitches. Otherwise, do interrupted stitches with nylon or proline, nylon stitches usually, and or you can use the staples also. And patient same on day 1, we usually keep her knee lowly for 6 hours or so, but ERAS, early recovery after cesarean, after surgery, is very common these days. So we start early fluid to the patient and early ambulation, and usually within 6 hours we can start her oral fluids and all. Give the catheter for 24 hours next morning and give her an antibiotics in the form of ampicillin or amoxicillin or cefuroxime, one of them. And next day usually we remove the catheter, and the patient can be started oral semi-solid on the next day that her ball sound are there and she passing vein. And third day, second day, Khichdi Dalia semi-solid started. Day 3, we change the dressing, and oral antibiotic and oral normal diet can be started. And usually day 3 to 4 patient can be sent home. We don't keep the patient for 7 days. And stitches are removed on day 7 or day 8. So this is what we do in a cesarean section. So proper doing cesarean section by transverse incision will ensure that in subsequent pregnancy we can try for TOLAC or VBAAC. So thank you.
So there are a couple of questions for you. May I ask them?
Yeah, please.
Yeah. So whether 2-layer or single layer uterine closure is preferable. So what is your opinion about single or double layer closure?
So the coronary trial proved that both 1 and 2 layer closure are equally good. There was no increased risk of rupture uterus in subsequent pregnancy, either with 1 or 2nd layer. But still, other studies have shown that 2-layer closure is slightly better. So I think in exam the students can say this thing, but that we in our what you can answer in the exam in DNB or MD exam, what is the practice in your hospital? So you can say, because then if it's an MD exam, then your internal examiner will be your examiner. So they say which is a practice in our hospital to do 2-layer closure, and I feel for exam purposes in MD it's better to answer 2-layer closure, because definitely 2-layer closure gives better better hemostasis, better approximation, and you are in a better position. So 2-layer closure should be preferred for that reason. Though Coroni style, for which I was part, did not show any difference. But unfortunately, the repeat cesarean section were low. From 16,000, we had only 3,000 repeat pregnancies, and in that case also repeat cesarean were very rare. So that's why it was not enough. You can say enough powered, because of the number of cases became lesser. Lesser patient had actually pregnancy in the 3 years. So I think in exam it's better to say 2-layer closure than single-layer closure. But single-layer closure can also be done. Aim is that proper approximation has to be there. If you are doing 1 layer, then you have to do full thickness, avoid endometrium. If you are doing in 2 layer, inner 2/3 of the myometrium, outer 1/3 of the myometrium. So ultimately it will be same actually. So, but you can say that in our hospital, routinely we are doing 2-layer closure, then the internal examiner will support you. And in DNB also, you can say in our hospital, this is the practice. But 2-layer closure, no examiner can actually query about that. Even if the examiner is doing 1 layer, they will support you for 2-layer. With 1 layer, some examiners may question you actually. So, you better answer for exam to pass the exam will be 2-layer with Vicryl.
Okay, so there's one more question. What is the exact criteria for TOLAC? In a few places, they say that vaginal delivery, if is followed by 2 LSCS, then the 4th pregnancy can get a trial of labor. So, what is your
Absolutely.
opinion?
The American College of Gynae also has, initially it used to be, previous to cesarean was a indication for repeat cesarean section. But the ACOG American College has said that even in previous to cesarean, vaginal birth can be tried. And if the patient had 1 delivery after that, then definitely it is a proven this thing that her scar is okay. So we can, if she had 2 cesarean section, then 1 vaginal delivery, or 1 cesarean section, 1 vaginal delivery, then she is a very, very suitable case for another vaginal delivery. You should give a try.
Okay, sir. One last question is whenever the upper segment is too thick and the lower segment is, or the lower edge is very thin, how do we approximate these edges? Often it turns out that you have taken an incision and the upper edge is very thick and the lower edge is very thin, and it ends up shearing off the lower segment or the
Yeah,
lower
in
edge.
that case, because if it is very thick, then usually the lower segment is so thinned out that you can't, 2-layer closure will not be possible in such case. So this is a case where single layer closure may be enough, but sometimes if you are having this thing in the same area, you can put another layer. Basically taking upper segment part and lower segment will be in the same part only because it's so thinned out. So that is what can be done for this case.
Okay, okay. So that's it from this session. Sir, does Dr. Tejas pass? I mean, he has been passing with a gold medal every time. So does he pass again this time?
Yeah, of course. Tejas, not only pass,
Sir,
he gets silver medal.
I have one question from my side for you, which is that what time do you think should we stop going for if she has not gone into labor, then when should a previous cesarean section be taken up for a elective cesarean section?
All the guidelines say 39.
Yeah,
Because a lot of, I think RCOG is saying up to 41 weeks, if I'm
no,
not
not
wrong.
41. In India, we never take beyond 40 days. No, there has been a study published in UK on Asian ethnicity versus local. So Indian fetuses tend to mature 1 week in advance. So our 40 weeks will be equivalent to their 41 weeks. So we never let the patient go into post-term because our babies mature 1 week in advance, Indian babies. So that's why beyond 40 weeks, we will never go. So if she doesn't go into labor till 40 weeks, it's better to do elective cesarean on her. We don't go up to 41 weeks. In UK, they go. I work there, they go because but it has been study done in UK only on Asian ethnicity plus local, British ethnicity. And they found that Indian babies mature 1 week in advance. So that's why we avoid the patient going into postpartum because we have seen patient having intermittent death, meconic stain liquor, and, after 40 weeks.
Hmm.
Even our babies start showing signs of post-maturity between 39 to 40 weeks. So it is, I
Absolutely,
think,
absolutely.
also said that you should induce them for labor between 39 and 40 and not wait till 41. I mean, maximum
In
you
fact,
wait till
electric
40.
cesarean is done at 38 weeks always, no? Usually 38 to
In our
39 weeks.
country, yeah, we
Though
should not
ACOG
cross
now say
40.
39 weeks, but still I tend to do at 38 weeks. In some patients where we waited, actually, I was just trying to do because they calculated on Thursday and on Sunday itself, patient had some change and some decreased movements. So then I had to do it on, early morning only. So usually at 38 weeks, I mean, in exam, the students should answer 38 weeks is the ideal time, no, to do repeat cesarean section or to do, I mean, elective cesarean. So they can still ask questions later on. I mean, in next class also we can answer. So, but I think Tejas has relatively beautiful. But previous cesarean section is a very important case for exam. In theory also they can get a full question or short note. I mean, VBAAC can be short, very commonly asked question in exam as a short note. And in theory, in practical, you can get a previous cesarean is a commonly given case. So you better do it well, and you can. They expect examiner expect good answer from it because it's a common thing and not like malignancy or this thing. So you should be very good in this. And read the ACOG guideline given in Williams Obstetrics, my book also. What are the indication of doing VBAAC and what indication of doing cesarean section. So that should be clear. Like any previous hysterectomy. I mean, we discussed that already. Hysterectomy, classical cesarean section. Usually previous two cesarean section unless they had one delivery after that or rarely. So those are the or contracted pelvis. So those are the conditions you need to read. So thank you very much. I think Aditya, you can just conclude
Sir,
and
thank you so much for your invaluable time and insights, sir. And thank you,
Yes, sir.
Tejas,
Thank you.
for the excellent case presentation. Thank you so much,
Thank you.
everyone.